Hope I'm audible and visible. Can I get a quick thumbs up if my audio video is fine to all of you? So, welcome in the next session of Dermatology with me, Dr. Chesta Agarwal, your NEET PG educator on the best online platform that is Unacademy. Now, today in this session, we will be continuing our discussion and we will be discussing the questions on the one-liners, which is very, very important in dermatology. Now, before we go ahead, let us very quickly go through the regulars. On Unacademy, we have a lot of free live sessions, and this is the schedule till 24th of April. I request all of you to kindly use my code CHESTA10 and get yourself enrolled. Now, the plus subscription is for the Unacademy access of all the courses, quizzes from the top educators. An iconic subscription give you an access to both Unacademy and Prep Ladder. We have NEET PG Lite subscription. It's a very high selling product of Unacademy where you can access all the MCQs, practice test papers, 90 plus grand test, which is available free of cost. Which is available on a very limited amount on Android as well as web. We have MBBS Prof 1. We have recently launched it, and that is why we have a pre launch discount of 49.50 if you use the code CHESTA10. So kindly use this code and get yourself enrolled. This is specifically for those who are in their first year or second year of MBBS right now. We have also launched a daily practice paper, which is for those students who are plus students who have already paid for the classes. They can access the questions at the end of the session. We have a doubt clarification batch, which is very important, starting on April 6th. I congratulate to all the students who have cleared their FMG exam. We do have a lot of special class features or like this. I do take a free class every day 3 p.m. I would be requesting all my students to kindly be a part. Now many batches are starting. FMG batch April 20th. The NEET PG subscription, I would highly recommend all of you to either go with a 2 month of plus or they can go with 2 month of light. Please use my referral code CHESTA10 to get yourself enrolled. My code is CHESTA10. Please get yourself enrolled. It's very cheap, 2000 rupees. You can access the whole dermatology MCQ bank. And in 7600 rupees, you can have an access to all the classes of Unacademy. Now let's start with today's session of one-liners, which is very, very important. So let's start with the first question. I will be giving you a very less time per question because they are one-liners. So we don't need much time for answering a question. Right now we have 20 students live. I would be requesting all of you to please get or please write the answer in maximum amount or maximum number. So please give me the correct answer of this question. Very nice. Investigation of choice for diagnosis of epidermolysis bullosa. Please remember it is a mechanobullous disorder where you have congenital deficiency of one of the product of either one of the protein of either epidermis or dermis. And the best investigation which has to be done for this patient is electron microscopy. Very nice. Kaustubh, Shrujana, Ashmita, Shagufta and Soumya. Moving to the next question, inverted saucer-shaped lesions they are found in lepromatous leprosy, tuberculoid leprosy, borderline or indeterminate leprosy. Inverted saucer-shaped lesions are found in. Inverted saucer-shaped lesions are the features of. Anybody can tell me the correct answer. Lepromatous, tuberculoid, borderline or indeterminate type of leprosy. Very nice. Shagufta, Aditya, Kaustubh. Inverted saucer shape means it has perpendicular inner border and sloping outer border. Very sorry. So the outer border is sloping and inner border is perpendicular. And this is a very classical feature of borderline leprosy. Very classical feature of borderline leprosy. Clear? I hope this is very easy and everybody is right. The answer to this question is option number 3. Now, the next question is on your computer screen. Histioid leprosy is a feature of Jamin, Saima, Aditya, Shagufta. Histioid leprosy is. So, what is histioid leprosy? It's a variant of leprosy which is seen in those, or it manifests in those where you have either resistance to the anti-leprosy medicine, or you have stopped taking medicine and there is relapse. So, this is a feature which is seen in relapse of leprosy. Correct answer becomes option number 2. How will it present clinically? You have multiple 5 to 50 or even more subcutaneous nodules or cutaneous nodules also. Papules and nodules on skin as well as subcutaneous tissue which is completely asymptomatic. Very classical feature of histioid leprosy. Clear? Very classical feature of histioid leprosy. Next question. Okay, let me see where is the next question. The most common cutaneous manifestation seen in the patient with end-stage renal disease. The most common cutaneous manifestation seen in the patients with end-stage renal disease. Anyone has any confusion with the last question? Ujjwala, is there any confusion with the last question? See, what is histioid leprosy? This is a type or a variant of leprosy which is seen in those patients who have relapse of leprosy. Those who have relapse of leprosy. Now, relapse can occur because of two things. One is patient is not taking medicines, and that is why there is relapse. And another thing is patient is taking the medicine, but he has developed resistance to it. So, in both these conditions, patient will have relapse, and this relapse will manifest as multiple 5 to 50 nodules, which can be subcutaneous or cutaneous, and they are asymptomatic. This is known as very classical histioid leprosy. If this is clear, Ujjwala, I would request you to give me a quick thumbs up. The most common cutaneous manifestation in the patients of end-stage renal disease, please remember the correct answer is pruritus. All of them, pigmentation, pruritus, half and half name, and pseudoporphyrias, all are the features of end-stage renal disease. But if you have to pick the most common one, the correct answer is option number 2, that is pruritus. Next, skin changes in hypothyroidism is characterized by all except amalgamate, combat, Kaustubh, then we have Shagufta, Ujjwala, Saima, Jaimin, Aditya. Everyone give me a quick thumbs up if all these points are clear. And try to answer the next question given on your computer screen. Skin changes in hypothyroidism are characterized by all except sign of Hertoghe, aurantiasis cutis, dry coarse skin, or palmar erythema. Please remember, the correct answer of this question is option number 4. Palmar erythema is a feature of hyperthyroidism. Very nice. It's a feature of hyperthyroidism. What is sign of Hertoghe? It is the loss of lateral one third of the eyebrows. Loss of lateral one third of the eyebrows. Okay. Loss of lateral one third of the eyebrows. It is sign of Hertoghe. Then aurantiasis cutis. What is aurantiasis cutis? It is the yellowish discoloration of the skin. Yellowish discoloration of the skin, which occurs because of deposition of beta carotene due to beta carotene. Okay. So yellowish discoloration of skin because of deposition of beta carotene. Then dry coarse skin, that is the skin becomes very dry. It will look ecthyotic. All these features are the features of hypothyroidism except palmar erythema. Okay, I'm very sorry for this. Okay, very sorry. Yeah, let's moving to the next question. Which of the following is not a causative factor of acne? Which of the following is not a causative factor of acne? Androgen, oily food, bacterial proliferation, or hyperconification of the duct. Which is not a causative factor of acne? Shagufta, Shangamitra, amalgamate, Shagufta, Deepa, Jamin. Very nice. Please remember, oily food is not a causative factor. Then which food agent is the causative factor? It is the milk and milk product. Milk and milk product, as well as food with high glycemic index. Food with high glycemic index and milk product, both of them causes increase in insulin like growth factor 1, and because of this there is increased sebum production. So which of the following is not a causative factor of acne? The correct answer becomes the oily food. Can I get a quick thumbs up if this is clear to all of you? Please give me a quick thumbs up if this is clear. Next, which of the following is a specific lesion of acne? Papule, pustule, comedones, or a wheal? Papule, pustule, comedones, or a wheal? Which of the following is a specific lesion of acne vulgaris? Which of the following is the specific feature of acne vulgaris? Anyone can tell me the answer? Nice. Now, specific lesion of acne vulgaris is comedones. We have two type of comedones. One is open comedone and another is closed comedone. Open comedone is also known as blackhead. Now, why it is called as blackhead? Because there is a slight opening in the follicular outflow, and because of entry of oxygen, what happens? Because of entry of oxygen, the sebum gets oxidized and it is converted to black color. So, open comedones are blackheads, while closed comedone, because there is no entry of air, so the sebum remains white, it is known as white head. Okay, so comedones are the specific feature. Combat, obviously milk product includes everything. That is why I have specifically mentioned milk and milk product. Okay, which of the following is a sub-epidermal disease? Diarrhea disease, bullous impetigo, pemphigus foliaceus, or bullous pemphigoid? What is the correct answer here? What is the correct answer for this particular question? Anyone can tell me? What is the correct answer? Which of the following is a subepidermal disease? Anybody can tell me the answer? Very nice. Subepidermal means the level of split is below the epidermis. Now, can anybody tell me what type of bulla you will see in subepidermal disease? Flaccid or tense? What type of bulla you will see here? Flaccid or tense? In this patients, you will see tense bulla because the whole thickness of epidermis form the roof. In diarrhea disease, you see suprabasal cleft, basal or suprabasal cleft. So that is not the answer. In bullous impetigo, you will see subcorneal split because desmoglein 1 is affected. So this is also not the answer. And in pemphigus foliaceus also, subcorneal split is seen because of affection of desmoglein 1. So the correct answer is bullous pemphigoid, where you have IgG antibodies against the component of the basement membrane. Okay, so bullous pemphigoid is the correct answer for this particular question. Which of the following is the rare variety of pemphigus? Which of the following is the rare variety of pemphigus? Pemphigus vulgaris, pemphigus vegetans, pemphigus foliaceus, or dermatitis herpetiformis? Which of the following is the rarest variant of pemphigus? Anyone can tell me the answer here? Yes. So the rarest variety of pemphigus is pemphigus vegetans, while the commonest variety is pemphigus vulgaris. Now, vegetans is a very different type of presentation. It has a verrucous growth. Instead of bulla, you see verrucous growth on the flexures like axilla, groin. intermemory area, etc. So it's a little rare variety of pemphigus. Which drug is most commonly implicated in drug-induced pemphigus? Which drug is most commonly implicated in drug-induced pemphigus? Penicillamine, ACE inhibitors, beta blockers, or aminoglycoside? Please remember one thing, that in drug-induced pemphigus, we do not have any autoantibodies. The drugs which consist of thiol group, it reacts with desmoglein, which also have thiol group on them. And you all know that there is biochemical interaction on whenever two equal or two similar objects come together, right? So biochemical interaction occurs. Biochemical interaction occurs, and this will cause the damage in desmoglein 1. So drug-induced pemphigus will mainly present with pemphigus foliaceous-like picture. And the most common drug implicated is penicillamine. Okay, so Shrujana, it is not option number 4, it is option number 1. Penicillamine is the most frequently involved drug. Which of the following is the commonest association of a paraneoplastic pemphigus patients? Anyone? What is the commonest association of a paraneoplastic pemphigus? Chronic lymphocytic leukemias, thymoma, non-Hodgkin's lymphomas, Kesselman's disease. Which of the following is the most common associations of paraneoplastic pemphigus? Very nice. Kaustubh, Shagufta, Amalgamate, Sangam, Deepa, Shujan. So everybody's right. All the four all these four are associated with paraneoplastic pemphigus, but the commonest association is non-Hodgkin's lymphoma. In these individuals, in paraneoplastic pemphigus, you see IgG antibodies against different components like desmoglein 3, desmoglein 1, against the plaquin group of desmosome. Even you can see the antibodies against the BP antigen 1 and BP antigen 2. And because of this multiple antibodies, you have uh, polymorphous lesions, lesions of multiple morphology, polymorphous lesions. Okay, you have polymorphous lesions. They are highly recalcitrant, very difficult to treat, and both flaccid or tense bulla can be seen because the target antigen is against different molecules. Which of the following is the most common type of psoriatic arthritis? Which of the following is the most common type of psoriatic arthritis? Can anybody tell me the answer of this question? Very nice. Shrujan, Nana, Sangam, Praveen. The psoriatic arthritis, the joint involvement occurs in around 5% of the total psoriatic patients. For diagnosing this, we have Mole and Wright criteria. It says that you should have cutaneous lesions of psoriasis. It should be negative for RF factor. The rheumatoid factor should be absent. And arthritis should be there, which can be of any type. Classic psoriatic arthritis, arthritis mutilans, asymmetrical, symmetrical polyarthritis, and the last is DIP only. So any of these 5 types of arthritis can be seen in psoriasis patients, but the commonest is asymmetrical oligoarthritis. Classic psoriatic arthritis is not common. It is asymmetrical oligoarthritis which is common. Clear all of you? Can I get a quick thumbs up? Jamin, Sameer, Shrujan, Neat. Hutchison syphilitic triad includes all except. Hutchison syphilitic triad includes all except notched incisors, nerve deafness, interstitial keratitis, clutton joint, etc. Hutchison syphilitic triad is a feature of congenital syphilis. In congenital syphilis, you see this triad, and you have to tell that which is not the part of this particular triad. Anyone? Yes, the answer is option number 4. The notched incisors. This is nothing but Hutchinson's teeth. Then you have eighth nerve deafness, and you have interstitial keratitis. All these three form the triad. While Clutton joint is the swelling of the knee joint, pain and swelling of the knee joint. And because of this pain and swelling, the patient will not move, giving a pseudo paralysis like features. Pseudo paralysis of Clutton joint is not a part of Hutchison syphilitic triad. Early eruption of secondary syphilis are all except early features of secondary syphilis are all except intensely pruritic lesions, papule and macular eruptions, symmetrical pleomorphic lesions. Very nice. Please remember in secondary syphilis, you will never see itching and you will never see vesicles. These two features you will never see. Other than this, anything can happen, and because of which it has given a name, and that is great imitator. Why we have given this name? Because it can imitate any disease, but whatever it will have, it will never go with vesicles and it will never have itching associated with it. Crystalline malaria is due to obstruction too. Crystalline malaria is due to obstruction to sebaceous gland, sweat gland, hair root, or accessory sweat glands. Why do you see crystalline malaria? Very nice. So what happens? The eccrine sweat gland, it opens directly into the skin like this. So this is your dermoepidermal junction and you have eccrine gland. Now depending upon the level of obstruction, we have different type of malaria. If the level is stratum corneum, we have Miliaria crystallina. If the level of obstruction is at stratum malpighian, it is Miliaria rubra. And if the obstruction is at dermoepidermal junction, then it is Miliaria profunda. Miliaria profunda. I hope this is clear to all of you. Now, we are ending this session right now, but we are continuing the same one-liners on the app now. So, I would request all of you to please download the Unacademy Learning app. At 3 p.m., that is after 5 minutes, I'll be live again and I will be continuing with one-liners in dermatology. So, just download the Unacademy Learning app and watch my session for free. It's a free live special class which is free. So I will be continuing taking the class ahead from this part on the app. If they ask you for any code, you can use this code and get yourself enrolled. Plus, you can unlock all the free sessions of all the educator on an academy using this referral code. So bye bye all of you. We'll see you soon after 4 minutes on the Unacademy Learning app. Till then, download the app, subscribe this YouTube channel, and please don't forget to give me a thumbs up to this video. Bye bye. Good day and